Good evening, and welcome to the second installment of Sage on Stage. My name is Chuck Cassidy. I'm chair of the orthopedic department at Tufts Medical Center and a member of the AO North America Hand Education Committee. And our guest, Sage, this evening is Dr. Peter Stern. Peter is an icon in orthopedics. As we all know, he's past president of the ABOS, the Hand Society, and AOA. He was deputy editor of JBJS and chair of the orthopedic department at Cincinnati for 22 years. An amazing educator and a wonderful person. I will be trying to extract pearls of wisdom from Peter, and Jeff is in the background behind the scenes. Jeff Lawton will be answering questions that you may pose during the session. Disclosure as listed. All of your microphones have been muted and the videos turned off. Please send your questions through the Q&A, not the chat, but the Q&A. And Jeff Lawton will review the questions as they appear and respond to them or save them and present them to Peter during the course of discussion. Our inaugural Sage on Stage event was last week, and it was hosted by Jesse Jupiter. And Jesse and Peter are contemporaries, so it is appropriate that we're having them one after another. We have at least, I think, 300 attendees tonight. We have the series continues, as you can see down below, for the next few months. There will be a link to the recording that will be available through YouTube. It'll be sent out via Zoom 24 hours after the conclusion of this event. The Hand Education Committee also has another educational activity on Thursday evenings. And this Thursday is scaphoid fixation, volar, and the hypothenar fat pad flap. It's an engaging discussion, and hopefully you'll be able to attend. So Peter, you ready?
I'm ready, go for
it.
All
right. Question number one. We're gonna go through, I think, some trauma and some reconstructive, some arthritis, and some other things. Question number one, do you pronounce it Kienbox or Kienbox?
None of the above. It's, I say Kienbox. This is really pedantic, but if you're writing an article, it's supposed to be just K-I-E-N-B with an umlaut over the O, K with no apostrophe S on it. They've gotten rid of that, but I say Kienbox disease.
The apostrophe is not appropriate any longer. I agree with you. Here's our first case. She is a 40-year-old female homemaker. She's had several years of wrist pain, has worn a splint without much relief. How do you tackle this?
Okay, well, obviously we want to do a history and physical, and then I would imagine she's got a small amount of swelling and tenderness over the lunate. She probably has reduced range of motion of her wrist, or forearm range of motion is fine. Then I would look at the x-rays, and this is a fairly clear-cut case of Kienbox. There's a negative ulnar variance, which we see in about 80% of patients with Kienbox disease. And she has what appears to be a very fragmented lunate, multiple fractures. The typical fracture in Kienbox disease is usually a horizontal fracture in the coronal plane, but her lunate looks like it's dusted. In addition to that, there appears to be a modest amount of carpal collapse. That is, the proximal surface of the capitate is migrating into the lunate fossa of the distal radius. Interestingly, if I'm reading the x-ray correctly, her scaphoid does not appear significantly flexed, which is a little unusual, but her lunate is absolutely shattered. I
agree with you. Is this enough information for you? Would you like to consider any ancillary studies?
So interestingly, I probably would not get any additional studies. The question would be always in Kienbox disease, can you preserve the lunate, or are you at a stage when it should be salvaged? And although I've seen the case, my preference would be towards a salvage procedure. I don't think that this lunate is salvageable.
I agree with you. So she came to me with this MR, and as you mentioned, you can see the fracture. There are actually several fracture lines you can see in the axial and the sagittal images.
And I want to point out one other thing, Chuck. If you look in the lower right at the sagittal image, it's a great image showing an increase in what's called the stall index. Normally, the transverse width of the lunate to the height is 1 to 2, but here the capitate is like a nutcracker into the lunate fossa, and the the lunate is markedly elongated. It's squished.
It certainly is. You said you don't routinely obtain these studies, and I don't either. But interestingly, this gave me some pause and cause for concern on this coronal image. You can see that there is some signal change in the proximal portion of the capitate, the head of the capitate.
Definitely, that's very useful. In addition to that, as you know, there's a Lichtman classification, and more recently, probably within the last 5 years, and I'm not an arthroscopist, but Greg Bain, a very talented surgeon from Australia, has an arthroscopic classification where he will look at the condition of not only the lunate but the hyaline cartilage and presence of degenerative changes and fractures. I think that you can get almost as much information with the 3D study or with the MR study which you're showing.
Do you use an interposition material, capsule, anything, in instances where the head of the capitate doesn't look good?
So if I was doing, for example, if I was doing a proximal carpectomy?
Yes.
Yeah, so good question. The answer is yes, but the secondary answer, I don't think it does much. So if you look at x-rays in the operating room, if you've done, for example, a capsular interposition, and I have no experience with resurfacing the head of the capitate with an implant or with an osteoarticular graft, but if you look at the x-rays, you see a great space between the head of the capitate and lunate facet to the distal radius, and then they come back 2 months later and it's gone. So I think it's a little hocus pocus. Dick Eaton, actually, when he did proximal carpectomies, when there was arthritis on the head of the capitate, would take a saw and take the most proximal 1 to 2 millimeters of the hamate and then just cut across perpendicular to the wrist and cut the proximal hamate, proximal capitate all the way across, and then do a capsular interposition. But I don't think they do a lot except treat us, but I do them.
All right. Interestingly, she had Kienbach on her other side and was treated 12 years earlier by my mentor, Dr. Ruby. And she's doing fairly well. You can see that her lunate is not in great shape. Is a radial shortening an option for her right wrist?
In my hands, probably not. I gotta say, it's amazing with Kienbach, and I'm sure everybody who's done any Kienbach surgery would agree. There is so much hocus pocus in terms of the surgeries that it's from non-operative treatment. There are many papers in the literature that would suggest that non-operative treatment for someone like this, for example, 6 to 8 weeks in a short arm cast followed by, a removable splint, and then let them go. They do very well. There's one actually from the Mayo Clinic. There's a Scandinavian series and others. 2 very, different types of aggressive surgery. Many years ago, we used to replace the lunate with an implant, but silicone or actually there were some titanium implants for a while, but those have completely fallen by the wayside because of wear debris, et cetera.
Speaking of hocus pocus, is there any role for any of these options? Arthroscopy, you mentioned, and I did scope, this is not that patient, but I did scope a patient after speaking with Greg Bain. Metaphyseal decompression, core decompression, or posterior or anterior interosseous neurectomy.
So I think it's, in terms of arthroscopy, I think or Greg would have you think that it's a reasonable thing to do. I think that as you demonstrated, your MR showed degenerative changes on the head of the capitate. There was also a little bit of decreased signal on the proximal pole of the hamate. I'm quite frankly not an arthroscopist. So I think it's reasonable in terms of staging and selecting treatment, but it's not something that I feel skilled enough that I would do, but I have no objections to it. In terms of AIN, PIN neurectomy, it's a very, very popular procedure. Dick Berger from Mayo Clinic a number of years ago, for all kinds of conditions in the wrist, did AIN, PIN neurectomies with a prior test of lidocaine just proximal to the DRUJ. And I believe between 65 and 70% of the patients, for the length of follow-up, which I can't remember, did pretty well. So it's always something that you can do. I see no downside. I've never seen a wrist that discombobulated, a Charcot wrist or anything like that. I cannot, Jesse Jupiter always knows the name of the person who did the radius osteotomy and decompression, scraping beneath the lunate facet of the distal radius from either Argentina or Brazil. Starts with an A, I think. I'm embarrassed, yeah. But
Laramendi.
Yeah, yes, Aramendes. At any rate, I've had, level 5 evidence, limited experience with this, 3 cases. One did okay, one did really well, and the third one was miserable and went to another doctor. I don't want to see Dr. Stern again. The concept is that you evoke a focal hyperemia around the lunate, and it mysteriously comes alive again. The problem is that the nutrition for the hyaline cartilage, the lunate, is synovial diffusion, and the bone gets its blood supply, obviously, from various perforating vessels, either from the dorsal lip, volar lip, or both. The so-called Gelberman X, Y, and I patterns.
So interestingly, her mother had Kienbach as well, bilaterally. And I treated her with proximal row carpectomies, and she was happy with that. But this patient wanted to try to avoid any extensive surgery, and so I did lidocaine test. She got great relief. I did posterior interosseous neurectomy, and didn't help. So she ended up with this. So as you've told us, these patients will develop radiographic arthritis. How do you counsel your patients?
You mean in terms of what
to expect long term?
Okay, well, some of it depends on the etiology, the reason that you're doing it, whether it's a slack wrist or Kienbach in this case. Lindley Wall, who was a fellow with us, looked up our results at a minimum of 20 years following proximal carpectomy. I've been a big fan of this operation, and about 2/3 of the patients after 20 years still had their carpectomized wrist. About 1/3 of them had gone on to a total wrist fusion. As you alluded to, there's really no correlation between the radiograph, that is narrowing between the head of the capitate and lunate facet to the distal radius, and how the patient does. I tell them all that they will not increase their range of motion. I tell them that their grip strength will probably not increase, or maybe a little bit. But overall, I think carpectomy is a reasonably good operation. we've we've published several papers on this topic, and there may be a correlation between age and how they do, and somewhere between the ages of 35 and 40, probably, particularly in a working person, you might select another option.
Would you like to disclose what that option would be?
So in Kienbach, I mean, it would depend. It would probably end up in Kienbach. In that case, say the patient was 25 or 30 years old, and a working man, I would think very strongly about doing a total wrist fusion. I don't think there's any place for wrist arthroplasty in young people, but that's based more on a referral practice where I've just seen a lot of disasters from wrist arthroplasties. I do think wrist arthroplasties are reasonable procedures in older patients. If my picture was on the screen, I don't know if it is or not, that would be the kind of patient maybe for an arthroplasty or a rheumatoid, but certainly not a young active person. It would.
Wise guy. My mentor, yeah. Dr. Ruby, would say, do the last operation first.
Yeah, that's extremely well put, and he was a wonderful, wonderful person. I love Len Ruby.
Well, hopefully we'll get to his paper in a little bit. Okay, number 2. You know the answer. The 4 most popular letters in hand surgery, LRTI. So with that in mind, we'll present this patient. This patient has basilar thumb pain. No tricks here. Has had a splinting and a couple of injections that provide her with temporary relief, but no longer beneficial.
And how old is she, Chuck?
She is a 42-year-old nurse.
Okay. Yeah, so she's miserable and she wants an operation. You've treated her conservatively. And again, no tricks here. I don't see, and I'm not trying to be obnoxious, a really good Betz view, but my guess would be, that this is a so-called Eaton or Eaton-Glickel stage 2 CMC arthritis. That is, there may be loose bodies or osteophytes less than 2 millimeters. There's a little subluxation. I can't see the MP joint. And one thing for those that are listening that I would mention, I think it's really important that you look at the MP joint when you're considering surgery on a patient with basal joint arthritis. And if there's considerable hyperextension, and I can't give you the exact number, you ought to think about either doing an MCP fusion or a capsulodesis. And I can go into that in more detail if you want, but it may be a waste of time. So let's assume that her MP joint is not hyperextended, and she's got 10, 15 degrees of compensatory hyperextension. I would pass on it. Let's assume that her STT joint and trapezial second metacarpal joint are intact. We're left with a patient that has stage 2 osteoarthritis.
Yeah, I've always had trouble with the 2 versus 3. I think 1 and 4 are pretty clear. 2 and 3, oftentimes when you operate on the patient, it's eburnated bone, regardless of.
You are dead on. We actually wrote, there are tons of papers on that very, looking at inter and intra observer errors, looking at the basal joint. And we published a paper a number of years ago, and 2 and 3 didn't do too well. The kappa values were quite good for 1 and 4. But 2 and 3 a little bit interchangeable. I'd have to go with the 2 here. So this is relatively early osteoarthritis, and your choices for early osteoarthritis again would be your favorite 4 letters, LRTI or some variant. The key in this, is I think everybody knows, is removing the trapezium. Whether or not you suspend it, whether or not you do some type of interposition, I think is dealer's choice. But the literature would certainly suggest that trapeziectomy is the key to the procedure, and whatever else you do is probably dealer's choice and very probable unnecessary. I personally feel that implants, which are extremely popular overseas, particularly in Europe, have no place in the management of this problem. For early on osteoarthritis, if you're not going to do some LRTI or variant thereof, I think the choices would probably be an osteotomy described by Wilson in the British Journal in the mid-70s, 1974, where you do very little science. You do a dorsal radial wedge-shaped osteotomy through the base of the thumb metacarpal, and then you close the wedge and fix it with a combination of either cerclage wires or K-pins. The idea being that in CMC arthritis, the anterior portion of the carpal metacarpal joint wears out first, and so you're redirecting forces and kind of we got hyaline cartilage on hyaline cartilage rather than eburnated bone. Another procedure which I don't do very frequently, but was very popular in the 80s, was the Eaton-Littler procedure, where a hemislip of distally based FCR was brought in a palmar to dorsal direction through the base of the thumb metacarpal and then secured to itself so as to prevent the subluxation. And Dr. Eaton, who was an incredibly honest reporter, had outstanding results in Eaton stage 1, 2, and even 3 osteoarthritis. So that would be another possibility. I reserve, but I don't do that operation very often unless, for example, I have a person who had a CMC dislocation who's either loose or redislocating. If a patient had laxity, say secondary to Ehlers-Danlos, I would do an arthrodesis of the CMC joint. And another option is fusion, and there are many, many techniques for stabilization, including plate fixation, cross K-pins, tension band, and memory staples, just to name a few. So a lot of options. The arthrodesis, well, why don't you show, I know what the next slide shows, so I'll make a comment after you show it, if that's okay, unless you have some questions.
No, well, no, the only, I have just a comment. This is anecdotal, but if it's in my practice, when I've done the ligament reconstruction, when there's arthritis present, even if it's relatively mild, the patients still have pain. Their joint is stable, but it still hurts. So I think the examples you mentioned, like Ehlers-Danlos or post-dislocation instability, I think those are great indications. So this one, for me, there's a little shelf, and I don't know whether it projected well, but it is subluxated, and her body's trying to stabilize the joint and not doing such a great job at it. And LRTI is a great operation, except when it's not. And almost everyone does well, but sometimes they don't. And she was a nurse at my hospital, and I just, I feared seeing her in the PACU where she worked after operating on her and having her be unhappy with this. She had very good MCP motion, and so I ended up doing this. And you mentioned the staples as an alternative. They're expensive, but do not require hardware removal. One paper I think you wrote mentioned that the complication rate from plate fixation is pretty high. In fact, K-wire fixation may be better than plates. This seems, it's a more recent option, and it worked in this instance. And this is her at about 3 months after her surgery. And so to casually look at her, you wouldn't know that she has a CMC fusion, and she's very happy with it.
So that's a tremendous result, Chuck. I just a couple things. One of the questions that people ask about. So first of all, a reasonably recent paper in JBJS dumped all over arthrodesis. It was by Vermeulen, and I think from the Netherlands. And the bottom line was, it was a very well-designed study, level 1 study, fusion versus excisional LRTI type of thing. And if you want to get something published in JBJS, do a level 1 study and then stop in the middle of the study because one of the arms is doing terribly. And that's a guaranteed publication for you. Anyway, they had 2 non-unions out of 17, and they prematurely stopped the study. And that's always been the biggest criticism of arthrodesis, is non-union. But the interesting thing, and the rate of non-union is about 10%, but the interesting thing is that many non-unions are radiographically problematic, but clinically they are minimally symptomatic. So I still think this is a very reasonable option, particularly for a younger individual. And you've got a terrific, at least 2-year result there.
What would you say would be the youngest age that you would consider an LRTI or equivalent procedure, trapeziectomy procedure?
I would do one. Probably 40 would be my cutoff. Some people will do an you don't see unless it's post-traumatic, and then you might lean towards a fusion. You don't generally see osteoarthritic joints much under the age of 40. I mean, they certainly occur, but so I would lean more towards a fusion in someone in that age group. And we have follow-ups. I have follow-ups of patients like the one that you showed earlier, 25, 30 years that are still doing well. Some of them will develop adjacent joint arthritis at the STT joint, but it's a great operation.
Peter, there was a question. Any thoughts on various tendons that you use for that transfer interposition, FCR versus wrist extensor?
Yeah, I don't think it matters. So first of all, so prior to the real LRTI that was kind of espoused by Dick Burton, Abe Frimson from Cleveland was balling up the palmaris longus and putting it in the space, so-called anchovy. He called it an anchovy. And if you look at the palmaris, and our palmari are all different, like you could shout into the wound and say, echo, 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 echo. And even using the FCR or abductor longus or a wrist extensor, I don't think you can come close to filling up that space. So I think that's hocus pocus dominocus, quite frankly. But if you ask me what I do, I use a counter to all evidence. So we have evidence-based medicine that says all you got to do is take the bone out. Do the original procedure described by Jervis in 1947. All you got to do is take the bone out. Everybody seems to do some additional thing. And of course, now with the tightrope, more additional procedure, more complications, et cetera, et cetera. Some of it might be RVU based, but I shouldn't say that cynically in a symposium like this.
You know what I say, the best place to hide a tendon is in the trapeziectomy opening, because if you ever revise one, and it looks like the tendon that you put in. You can unfurl it. You could use it for something else if you want. It doesn't really integrate.
Yeah, I agree with you, Chuck.
So you had mentioned metacarpal extension osteotomy. Just for those who haven't seen this technique, this is an example, and it's indicated, as you mentioned, for stage 1 and maybe stage 2.
Yeah.
Okay, change gears. Is it ever too late to do a carpal tunnel release?
All things being equal, I would say never too late. Even people who reach triple digits, I think it's reasonable. Now, you don't do the carpal tunnel release to make the atrophy of the thenar musculature go away. You would do it basically for pain relief. They end up having a lot of pain and sometimes paresthesias at night. I think, you know, there are papers, a lot of papers in the Journal of Hand Surgery which would support that contention. It's an incredibly easy procedure to do. It can be done under local in 10 minutes or so. I'm sure there are people that can do it faster than that, but speed kills. And so I think that it's a reasonable thing to do, not to improve motor function. If you want to improve motor function, you might consider a tendon transfer, such as the Kamitz transfer using the palmaris longus prolonged on the palmar fascia. It looks like, Chuck, does this patient have an incision? I may be hallucinating. Yeah, right in there.
Yeah, right there. I don't know what that was. But
Was that an old motor branch injury?
it was a motor neurectomy incision, apparently. I don't know. But I think when, as you mentioned, when they have pain, especially night pain, if they have nerve irritability symptoms, they're so grateful.
Yeah.
Sometimes patients, though, later, the nerve just kind of dies, and it's not painful. It just doesn't work well, and they have trouble with buttoning buttons, for example, or picking up coins.
Definitely, but I think that's, yeah, I mean, I agree with you. I think that's more the sensory changes are occurring. They've got atrophy of, I mean, exactly. The nerve is, if you do a real old-fashioned open carpal tunnel release, you actually look at the nerve. I mean, you will see true hourglass deformity. The nerve really looks bad. But I think it's the downside of doing a carpal tunnel release in general. I mean, we've all seen infections, we've all seen nerve injuries, stuff like that is pretty minimal. So particularly for patients that are having pain and night pain, I think it's beneficial.
Great. Well, that was a chip shot for you. This one's a little tougher. Is it ever too late to operate on cubital tunnel syndrome?
Well, it depends on what you're operating for. So this patient, what you're showing me here, I think, or I'm sure you are, is there's atrophy of the first dorsal interosseous. There's clawing of the ring and small fingers. And so the question is what are you operating for? Are you operating because the patient is experiencing pain in the ring and small fingers? Are you operating because they have motor dysfunction? They've got weakness of pinch, weakness of grip, inability to make a fist, unable to synchronously flex their fingers down. Or, you know, is it a sensory issue? I would assume, although not definite, that the compression, this is cubital tunnel, so the compression is at the elbow. Having said that, I certainly think that patients that have long-term established cubital tunnel syndrome with both sensory and motor findings, or they've got stiff fingers, I think it's a waste of time to operate. And the most I can do for them, I don't think I can easily restore sensibility. And the most I can do is either some type of tendon transfers, or possibly if they've got fixed clawing, arthrodesis in a better position of the fourth and fifth fingers. But for long-standing cubital tunnel, mainly motor complaints, I would do tendon transfers for pinch and grip. So to correct the clawing, I would want to try to correct the clawing, and I would do a tendon transfer for pinch, which often in my hands don't always work very well. I don't know, and I should know, I'm out of it, whether or not there are any good nerve transfers that you could do. So my answer after verbal diarrhea is that it certainly can be too late to operate on cubital tunnel syndrome.
So this was an interesting patient. She was a woman in her 30s who had a tardy ulnar nerve palsy from a lateral condyle non-union. And she had a fairly rapidly progressive ulnar neuropathy. And someone did just an in situ decompression on her. And She didn't get it.
That would be, if you were taking your board exam, this is really obnoxious, okay? If you were taking your board exam and I was your examiner, I'd be tough on you for that. Because, you know, the nerve is being stretched in a cubitus valgus position, and you need to at least take the tension off the nerve. So it would seem to me that a more appropriate procedure would be moving the nerve anteriorly, whether you go, you know, subcutaneous, intra, or submuscular, might be dealer's choice. But anyway, sorry to interrupt.
No, that's okay. You may not remember, but you were my board's examiner.
Oh God.
You were a softie, actually. So one of my cases was a scapulothoracic fusion, and I have no idea what I was thinking doing that during my boards collection period. But you said, "That's cool. How do you do that operation?"
Peter, you were my board's examiner too.
Really?
You gotta be kidding! You gotta be kidding me!
That's not how we got randomly picked to be the moderators, but
that is funny. And then I had a patient with necrotizing fasciitis who died, and I was very worried because it was a patient from the VA back in the day, pre-electronic medical record, and the notes were very sketchy. And you asked me, "What's my scrub side description of necrotizing fasciitis to a medical student?" And I answered, and we went on to the next patient. So you were a softie.
Yeah, well, I think you probably knew your stuff pretty well.
So, but back to this patient. So I did an ulnar transposition, and
I'm glad you didn't do an inside two.
No, having read some of Susan McKinnon's stuff, I did an end to side AIN to ulnar motor not transecting the motor nerve, but an AIN to end to side, and she recovered incredibly. You know, it said that they don't recover intrinsic muscle function or atrophy if they have atrophy to this degree. She was young enough that she actually got back just about normal hand function. But I don't know. It was probably just the nerve transposition and not the supercharge. But
yeah, you know, again, I'm not a neuroscientist. I'm not Susan McKinnon. But if everybody knows, basically what Dr. Cassidy's talking about is you take the anterior interosseous nerve, median innervated, and you take it as far distal as you can, and in kind of mid-substance of the pronator quadratus, and then you join that end-to-side to the motor branch, the ulnar nerve. If you look in a cross-section of the ulnar nerve, the motor branch is deep and ulnar. And I just think that's hocus pocus, but you have absolutely proved me wrong, because I don't think your success was based proximally. How fast do you remember did she recover?
So this is the story. So by the time she came back to the office for her first post-op visit, she had some intrinsic function. She had nothing before I operated on her. Wow. So obviously it was the transposition that that did the job. But
awesome.
Next, okay. We mentioned Dr. Ruby, one of my mentors with Dr. Belsky. True or false? This paper came out in 1985. He concluded that a scaphoid non-union would uniformly result in arthritis if left untreated.
I would have to say that it's more true than false. I'll waft a little bit. We certainly, when we see a patient I saw a patient today with a scaphoid fracture, and one of the things that I think most orthopedic hand surgeons or whoever would tell them that if this goes untreated, particularly if there's any displacement or presence of a DISI posture, that they're going to eventually get arthritis. The key thing is with a snack wrist, and I think this is really important, and we wrote a paper on it a number of years ago, is that not everybody who has a horrible looking wrist is very symptomatic. They may have some minor problems, but they're living with it. For example, many patients that I've seen that have had a snack wrist with advanced arthritis will come in with carpal tunnel syndrome. And you take an x-ray of their, like the 206 thing, you take an x-ray of it, and it's just, you need a wrist fusion tomorrow, 2006. You need that fused. And they said, but my problem is I've got numbness and tingling in my fingers. And I think what happens is the carpal canal kind of volumetrically decreases or rearranges. I have no proof of that. And you end up doing a carpal tunnel release, and they have improvement in symptoms. You may not hit a home run. And they're perfectly comfortable living with this god-awful looking wrist with carpal collapse and arthritis, et cetera, et cetera. I mean, here, you know, look at what's happened over this 30-year period. The wrist is absolutely gone to pieces. So let me ask you, Chuck, in this patient, did they come for a wrist fusion or a carpal tunnel or none of the above?
So I met the patient in 2006, and he brought with him dutifully x-rays, the old-fashioned x-rays that he had taken of his wrist in 1974. He had two complaints. One is he wanted to know what the bump was at the base of his thumb in the radial styloid area. Mm-hmm. And the other was he had numbness in his hand. His wrist was fine.
Yeah.
I did a carpal tunnel release on him.
Yeah.
That was it. You're right on.
Yeah. Well, thank you. The other thing you don't want to do, so I don't think many hand surgeons get x-rays on patients that have carpal tunnel syndrome. But if they have reduced range of motion of the wrist on physical examination, it may be reasonable to get an x-ray to look for a slack or snack wrist. And if they have that dorsal radial swelling, the worst thing you can do is a ganglionectomy. I guarantee you that in that situation, you will get to do another ganglionectomy. It's very similar to if a person has a Baker's cyst and you don't address the knee pathology, you know, tear the medial meniscus, posterior horn, you're going to get to operate again. So I like your selection of operation here.
Less is more, yeah. But let's move on to management of an acute or subacute problem. So here we concluded that they probably will, if it doesn't heal, run into trouble, but not always. So this is a patient 16, pain-free, non-tender after 6 weeks of casting. What do you think of the x-rays? What do you think of the time of immobilization and the plan?
I think that I think radiographically, even though the patients, you know, young people, they'll do anything to get out of a cast, including take their cast off. And I don't think this is healed. And I would be loath to let this person leave the office, especially a 16-year-old and presumably a male. I would be very loath to let that individual leave the office in, say, a removable splint, a thumb spica splint, or something of that nature. You can easily see a fracture line. So I would recommend continuing immobilization for fear that the fracture would not unite, and over the ensuing long period of time, degenerative arthritis would probably develop.
What's the role of CT in your practice with a patient like this?
Okay, so I generally use CT to look at geometry. I use CT to look for arthritis, adjacent joint arthritis, etc., humpback deformity, but it's kind of a geometric thing. If I'm more concerned with vascularity or making a diagnosis of a scaphoid fracture, I would lean more towards an MRI. The big question, which we briefly discussed either last week or tonight, is, you know, when you see a patient and you take all kinds of views and everything looks healed and they're asymptomatic, do you get an X-ray? Do you get a CT scan? And for me, I do not routinely get CT scans. I do take care of some of the the Bengals in Cincinnati, and categorically with a scaphoid fracture, they're going to get CTs every day. They use so much cross-sectional imaging, and they're in a different category certainly than certainly I am. So pro athletes and high stakes individuals, yes, but if physical examination and a series of plain radiographs don't show a fracture line, I'm not going to order a CT to assess for union. And the number that I believe is quoted for people ask, well, how much of it do you need to see trabecular bridging? And Greg Summerclamp has pulled out of his derriere 50%. I have no idea. I don't think there's any biomechanical studies to support it, but maybe somebody listening in can give me a reference and I can educate myself.
We actually did a study with Dr. Ruby. It was a cadaver study where we incrementally cut more and more through scaphoids and tested them on an instron. And it turned out in the study that if it was less, if we're going to translate it to healing, if it's less than 70% healed, it's only 30% as strong as a normal scaphoid. So
I'll have to read that. That's interesting.
Which is pretty much like an open section defect. If you, the way I remember it is a third, the same thing of a third the diameter of the bone. It translates pretty well in that way. But this patient, I guess the feeling was that the patient, the fracture was healed enough. And then some subsequent x-rays were obtained at 10 weeks.
Okay, so, here, Houston, we have a little bit of a problem. So the proximal pole, again, is very difficult. Maybe a little tiny bit sclerotic, may not be, hard to say. There's categorically a resorption at the fracture site, and you're starting to get, kind of a sclerotic non-union. It's very difficult on the lateral view for me to see for sure I think I can see the proximal and distal poles of the scaphoid, but I would bet if you did CT scanning in the plane of the scaphoid, you'd see a humpback deformity with some carpal collapse. I'm trying to look at the lunate and seeing along the lines of carpal collapse whether there's any extension of the lunate, and I'm not sure I can tell.
Yeah, I think it is extended. If you look at the capitate, the image quality on the lateral is not the best, but the capitate's translated dorsally relative to the radius.
Yes.
It's uncovered a fair amount. So
Yep.
And so yes, we did fix it, and I did put a bone graft in. Actually, it had collapsed, and through a volar approach.
So Chuck, I'll have you be the sage. It's a waist non-union. How do you decide whether you're going to go top or bottom?
Well, I think
I know why you went the direction you went, but I'm curious to know.
Yeah, well, I don't think we can reliably correct carpal collapse through a dorsal approach. At least I can't, and so and I feel more comfortable going volar. I think for waist fractures, for proximal pole fractures, dorsal is the answer. And if you're using a headless screw with a continuously variable pitch like this, the purchase, or if you want to call it compression, is much more at the trailing end. The translation, if you think of it like a gear, is much more on the trailing end than on the leading end. So you always want the screw to go from the smaller piece into the bigger piece. So then so that makes the answer easy, except for waist fracture. So if it's a waist fracture and it's collapsed, I will go volar. If it's not collapsed, I think you could argue going either way.
Sure, great.
Is that the right answer?
Yeah, I think.
Did I fail?
Did I answer? No. Yeah, you're going to come back to Chicago to the Palmer House next year, Chuck. I'm sorry. Don't vomit on me. No, I think it looks great. Home run out of the park.
All right. In the Corona crisis, we watched Monty Python in the Holy Grail, and it reminded me of seminal paper, The Holy Grail, that I read in 1992 when I was on the hand service by your friend, Dr. Telesnik and Dr. Cohen, and concluded, and this is the only hard data we're going to present tonight, but direct repair and capsulodesis, 24 out of 27 excellent results, normal grip strength, the scapholunate angle was improved, the scapholunate gap was corrected. Why can't that be replicated?
I'm not sure I can give you an answer. I do have to do a little historical stuff. So Julio Telesnik was really in the 70s, 80s, and into the 90s, was really a pioneer in all types of carpal instabilities. Mark Cohen was at Harvard Medical School, I believe at the time, and he did an outside rotation out in California, and he hooked up with Telesnik, and so he's the one who really put together the series, and he's now an elbow, primarily an elbow and hand surgeon in Chicago, and Lavernia is a total joint surgeon in Florida. So having said that, I can't, I've never asked Mark how they got such great results, but certainly in the 80s, in the early 80s, this was a very, very common procedure. The antecedent procedure was the so-called Blatt capsulodesis, and that was even more of a kind of bogus type of operation. And Dr. Blatt, again, reported outstanding results. He reported those at the Hand Society. Basically, he took some dorsal capsule based proximally on the dorsal radial lip of the radius, and he sutured it into the distal scaphoid so that rather than the scaphoid being vertical, he was able to bring it up into a more extended posture. There was nothing done to correct, he said you didn't need to correct the scapholunate gap. And he showed videos at a Hand Society meeting and had really good results. That procedure also was fairly popular, but the scapholunate instability, as I ride into the sunset, remains a very, very difficult problem. Many patients end up with kind of bad looking x-rays after all kinds of procedure, ligament weaves of many, many types, but they seem to function reasonably well. Maybe it's the hot poker treatment. You know, you've hurt me enough, doctor. I don't want anything more done. But these are, you know, these are great results, and these are certainly Julio Telesnik and Mark Cohen are extremely honest individuals. Very rarely have I seen scapholunate. You're going to show it here. So this patient in my hands would not do well with any type of repair, whether you Mel Rosenwasser would do a Rassel procedure. In Mississippi, Will Geisser would put some magical screw in the scaphoid and lunate. Mark Ross over in Australia would thread a tendon graft from scaphoid to lunate. I can't even drill one hole in a bone without fracturing it. To the triquetrum, others would do a variety of tendon reconstructions. I think most of them fall apart. And for someone who has a 5 millimeter gap and a 90-degree angulation, and his lunate's almost looking at the moon there, this patient in my hands would get a salvage procedure. If I was at the Mayo Clinic, if they were nice enough to invite me to do a case up there like this, they would vomit if they did anything short. They're reconstructive ologists. I hope I'm not offending anybody. They believe that wrist motion is sacred, and they will do anything to preserve all of the carpal bones. I would argue extremely obnoxiously that wrist motion is overrated and forearm and finger motion are underrated. End of dictation. I know you're asking me to get off now.
No, not at all. I want to know what the answer is. So you said a salvage procedure, but the SAGE didn't come out with what's the operation of choice for you?
So believe it or not, even though I poo-pooed carpectomy in a 30-year-old, I just, Chuck, I cannot see this operation working. I think I've seen that you did a great job on it through, you know, a Brunelli or something like that. But geez, 5 millimeter gap, that's, oh my Lord, I don't know how you can reduce that. It may be reducible in the operating room, maybe if you pin it long enough, or you do the Rosenwasser procedure, which I've also dumped on. It didn't work in Cincinnati, and he's never let me forget that. I would do a carpectomy on this patient if they were symptomatic. Sorry.
Yeah.
And I would get, and I guess the other thing, critical to get an X-ray of the other wrist. Critical. There are lots of people who, you know, have some type of defect in their collagen, and it's amazing the number of patients in my lifetime that have had operations for scapholunate instability, and the opposite wrist looks the same. So you did a Brunelli, you have a beautiful correction here. And in Cincinnati, if you referred this patient to me for follow-up care, and I took the pins out, say 2 months later, 3 months later, yeah, things would fall apart.
Yeah, I think a couple of points that you raised. One is, you know, whether this is really an acute injury, and as patients get older, we are concerned that they may have had a prior injury that they just dismissed as just a wrist sprain, and this really was an acute injury, and thankfully did okay. And the second is, for me, I think of it more like a Lisfranc injury, and I agree. I would leave the pins in for a long time and accept some stiffness. And so this is a year post-op, and you can see this lost a little bit of the scapholunate angle. Scaphoid's flexed slightly, but it's he's not in DC, and he did well. Lost some wrist flexion,
yeah,
but did well.
Very impressive.
Jeff, do you have any burning questions? Well, Peter, I was going to ask, and I agree. I'm inclined to do a salvage as well. I just wanted to get your thoughts on, you said PRC. There is a little bit of a school of thought of, maybe in a younger patient, something like a midcarpal arthrodesis, four-corner fusion, or capitolunate fusion. What are your thoughts on those in a younger patient?
I think that's actually, I think that's a better choice. I think a four-corner fusion or just a capitolunate fusion would be a better choice in this situation in a 30-year-old. I had a little brain attack there, but I agree with you, Jeff. I think that would be my preferred procedure. The only problem with four-corner, the problem with four-corner fusions, in my opinion, is that it's got to be done right, and you have to really have good carpentry, work on the capitolunate, particularly the capitolunate joint. And if you can get good cancellous bone on good cancellous bone, regardless of what technique you use, whether it's staples, cape pins, circular plate, whatever, you're going to have, and you're able to obtain, pardon me, a reduction of the lunate, you're going to have a happy patient by and large. The problem is that oftentimes we don't get a great reduction, or we end up with a non-union or some type of hardware-related problems, and then things go south. But if you can get a solid fusion in a reduced lunate, I think those patients long-term, if you match them one-to-one with patients that had a carpectomy, I think long-term, and there aren't series at the 20-year level yet, I think the four-corner fusion is going to win the race. If you look at the current day literature, there's a lot of literature from Andy Tischer, from Salt Lake City. Kevin Chung has written on it. When they compare four-corner fusion to proximal carpectomy, carpectomy is winning the race in terms of economics, complications, et cetera, et cetera. And, a lot of literature which gives kudos to the carpectomy. But I think in this case, in a young patient, my choice would be a four-corner fusion, Jeff.
All right. I think I'm just going to show you this case. And the question is, how could this possibly have happened to this poor person? But the real question to answer is, what do you do about a failed DARA? So this patient has, you could see a previous wrist fusion and radial ulnar impingement with some scalloping on the ulnar side of the radius. That had a couple of operations, shortening and then shorter.
Yeah, so I'm a big fan of the DARA procedure. Most people hate it, but it's a procedure that was, it's over a century old. It was described by DARA, who is the dean at Columbia Medical School in 1912, I believe, and it's still around. I think it's a reasonable operation for sure in rheumatoids, but we don't see a lot of rheumatoids anymore, but it's a very good operation in rheumatoids, and it's not a bad operation in older patients that have a distal radius fracture treated non-operatively, where you got radius shortening and a prominent ulnar head with ulnar abutment into the carpus. The problem, as has been pointed out, there's a great quotation, and I can't give you the source, by Jim Dobbins from the Mayo Clinic, and he. Once you have a failed DARA, that's a big problem. And it is very, very, very difficult to salvage that. Here you can see, as you pointed out, the little notch on the ulnar aspect of the radius where there's convergence of the unstable ulnar head, not only radial-ulnarly, but probably dorsal palmarly. And that's very difficult to correct. Dean Soterianos from Pittsburgh, Pennsylvania, would interpose fasciolata to keep the bones separated. There are a variety of tendon transfers that have been done, and but the thing that probably works the best in this very difficult situation is an implant. Dr. Schecker, who will be your next speaker. The problem with the implant, and Dr. Schecker is probably one of the nicest people you ever met, and he is just a prince, and he is passionate about this damn implant. So you got to be a little careful, but in this situation, it's definitely a bailout. A one bone forearm is a fairly debilitating operation, but would also be an option if you're not familiar with the implant. So I think, interposition, Soterianos operation, implant arthroplasty, ligamentous stabilization, I don't think would work, or one bone forearm, which is fairly debilitating. Losing forearm rotation with a wrist that is fused. Generally, you're not supposed to do, or the recommendations are with a one bone forearm, that you do not do this procedure if the wrist is stiff, i.e. a fused wrist, or the elbow is stiff. You want to have flexion extension of the wrist and elbow, because you lose all rotation.
What about taking more ulna?
Okay, so
Scott Wolf, what do you think about that?
the Scott Wolf operation. So Scott Wolf and about 8 or 9 other people contributed to it. And basically what he said is you do an extended DARA procedure, and you can take up to, I believe, 1/3 of the ulna. So it looks like this patient has already partially had the Scott Wolf operation. You probably could take a little bit more, but I don't think it's going to work. I think this patient, sadly, and I have no idea how they got from a reasonably well-reduced wrist to frickin' fusion and shortened ulna, but that's what makes our specialty so great.
This was a challenge. So she had an attempted one bone forearm, radius on ulna. And about 2 weeks after her surgery, she heard a crack, like a tree falling, she said, and had this. And so she came to me with a fixator on, and lots of questions. And so because of for the sake of time, I just try to simplify it and just fix the radius. And I was hoping that that would be sufficient and wouldn't have to address the radial ulnar impingement, but she continued to have symptoms. And I did that operation that you had just mentioned, which is a prelude to next week, 2 weeks from now.
Can you just go back, Chuck? I want to ask you an ethical question.
Yes.
So she go back one more. She comes to you with these X-rays, and she said, "My dad is an orthopedic surgeon, and he's not sure this one bone forearm operation was done correctly." Could you comment on the plate fixation and whether or not bone graft was used?
I don't know whether bone graft was used. So there are two techniques well, there are several techniques for radius to forearm fusions. You could leave the space, the interosseous space, and put a graft that bridges the two bones. And that would historically was with iliac crest. You can converge the ulna into the radius, which I've done. I like that, especially if they've had a prior distal ulnar resection, and you get a broad surface area with multiple interfragmentary screws. Or the third is this radius on ulna, where the surgeon attempted to, as you can see on the image on the right, put the distal radius on the shaft of the ulna, and there's a lot of stress in doing that. And the plate was short, and the screws were eccentric. I think they were at least a couple were unicortical screws or transcortical screws, and just popped off. But I think you're absolutely right about the prior wrist fusion. I would say is a relative contraindication to do a one bone forearm, and that was probably not the best idea. Yeah, but there's no end to the number of operations that a surgeon can do on a patient in certain circumstances, and that's sort of the path that was taken in this instance. But
I think the other thing, the best article I think even today was written. It's out of Mayo Clinic by someone named Peterson as the lead author, and these are, regardless of whether you do any one of the three operations which you mentioned, there's about a 30% non-union rate. Now they did them for a variety of reasons: infection, trauma. I think they did a one bone forearm and an ulnar aplasia case. But the bottom line is that this is not always a slam dunk operation, and certainly, in my opinion, the loss of forearm rotation is very debilitating.
And this, I think this implant was a good bailout, but she is only 30 years old, so I don't think it's the end of the road for her with respect to this. But short term, she's happy.
Yeah, it's beautiful, beautiful salvage.
But I think, alas, I think we've run out of time. Jeff, are there any outstanding questions? I think you're on mute, Jeff.
The question, Peter, there was a question on your thoughts of a DERA for someone with a radial malunion that's relatively well aligned, but just results in ulnar positive variant.
I think so. We've looked up our cases with that, and they, in general, in older people that look like me and worse, that's a reasonable thing to do. I would say that in a relatively sedentary individual over the age of 50, it's very reasonable. It's a very, very simple operation, but unfortunately, as Chuck pointed out, sometimes they just don't work. And in that case, the salvage procedures are pretty big league.
Right.
Thanks, Chuck. Those are great cases.
Yeah, that was, Chuck, kudos. I mean, those are great cases for discussion. And you were, Chuck was very kind. He let me look at the cases beforehand so I wouldn't look like a complete buffoon. Thank you for putting them together.
Those were great comments.
Yeah.
Thank you. And I was trying to get to, here it is. As I mentioned earlier, we have a session coming up this Thursday in 2 days at the scaphoid fixation through a volar approach and the hypothenar fat pad flap. It's at 8 p.m. Eastern time, 8 to 9 hour long session, plenty of interaction. It's been a great series. I want to thank you, Dr. Stern, for taking the time Always great to see you, and
Yeah, you bet.
Thanks, Peter.
Yeah.
great pearls of wisdom.
Thanks, Chuck.
Appreciate it.
Yeah.
Thank
Thank
Jeff.
you, Jeff and Chuck. Appreciate it.